Okay, welcome back to part 2 of chapter 23 on the respiratory system. So we just got done talking about all the way down to the structural anatomy of your conducting airway, conducting portion of the respiratory airway from your trachea, or your nose all the way down to your respiratory bronchiole. So now we're finally getting into our respiratory portion of the respiratory system, which is our alveoli. Very important, critical structure that allows us to breathe. Okay, without our alveoli, there is no sense of, no way of allowing oxygen to diffuse into our blood and distribution across the body. So each respiratory bronchiole is attached to a bunch of alveolar sacs like this, and where each alveolar sac contains chambers. If you look inside here, how it's cut open for you to see the little curvy chambers within that is connecting the multiple amount of alveoli within those area. Each lung contain about 150 million of these alveoli. Okay, that's how much of these little balloon-looking things we have. Okay, with that much gas exchange surfaces, you can see how high of an important it is to ensure we have enough oxygen coming in and also making sure that carbon dioxide is released. There's a purpose why we have all these alveoli in there, because they are all very critical for efficient gas exchange that we're able to do. Now, each alveolus is surrounded by an extensive network of capillary and elastic fibers. Now, these capillaries are, of course, delivering blood to those areas for oxygen pickup. Now, the elastic fibers, on the other hand, are kind of like what the blood vessels are doing with elastic recoil. So the alveoli also need to recoil during exhalation to reduce the size of the alveoli that can assist with pushing air out of the lungs. So literally, they're kind of like little tiny balloons all over your lungs for taking in air and pushing out air. Okay, so remember, capillaries for the actual exchange of gases for oxygen to migrate into your blood. Elastic fibers is to help with the recoil of these alveoli, little pockets or balloons. And as we have already discussed, the alveoli is made up of simple squamous epithelium. So don't forget that. And it is, instead of endothelial cell, the alveoli's epithelium is made up of 3 different types of cells. You have the more numerous type of cell called the pneumocyte type 1. Okay, pneumocyte type 1, where, these little purple cells here, you see all these little purple cells? That's why I said they're kind of like your endothelial cell that makes up your blood vessels. Instead, you have these pneumocyte type 1 that makes up your alveoli sacs, okay? So, though they are the ones that is forming the main surfaces of your alveoli to allow gas to diffuse in and out. You can remember the name pneumocytes, okay? Pneumocytes with pneumonia, if you already relate that word to lungs, if you think about pneumonia. You also have alveolar macrophages, and we sort of briefly talked about it in the last chapter when we in the lymphatic system, when we said that there are free macrophages versus free macrophages within that roams around the alveolar sac. Okay, so free macrophages within the alveoli are called alveolar macrophages, and they kind of roam around each alveolar sacs to patrol for any pathogens or particle debris that needs to be cleaned up. Okay, so kind of like acting as our last defense this deep down into your lungs. Okay. There's a third type of cell called pneumocyte type 2 here, and these cells play a critical role of making an oily secretion called surfactant. Just like how our heart valves, we need a way to ensure that the walls of the that we need to make sure those valves, okay, or the cups of the valves from sticking to the side walls of the heart or blood vessels. We need a way to ensure that the walls of the alveoli don't collapse on us, where it's supposed to be open like this, but they end up doing this, where it gets stuck in the middle or something, because they do have that surface tension in there due to the fact there is that thin layer of water I was talking about in the alveoli walls. So they can technically stick to each other. And if that happens, we may need to take a deeper breath with more air to try to use air to forcibly separate the two layers again. And hence, to prevent this oily surfactant secreted by pneumocyte type 2, these little yellow cells here, these are the pneumocyte type 2, they will ensure that our alveoli surfaces are well separated from each other. There is a very thin layer of water, like I said, that coats each alveolar surfaces, and with the oil in there, it will help to reduce their surface tension towards each other. And since we talked about how vital it is for our cells to produce this oily secretion, that probably means there is a disease associated with it. And you're right. Respiratory distress syndrome is when somehow an individual makes an inadequate amount of surfactant produced by pneumocyte type 2 cells. And this can stem from damages to your respiratory surfaces, or sometimes from genetic abnormalities to begin with. In the end, it will result in more likelihood of alveoli to collapse on each other every time, and hence every time they breathe in, they will need to do, they will need to do so more forcefully to reopen the alveoli, like every time they breathe in. Okay, imagine how tough it is to breathe like that while breathe like as if you're running a mile when you're just sitting down doing nothing, and you have to breathe like that. Okay, so that's called respiratory distress syndrome. Now, all of these normal things that our body does for us without really, we having to think about it, oftentimes they're taken for granted until the capability is taken away when a condition or a disease arises. Okay, so the alveoli serve as our main blood-air barrier because gas comes into our lungs, and they would diffuse across the alveoli's epithelium in the blood into the blood plasma and picked up by erythrocytes or your red blood cells. Now, even though the epithelium is thin, there are still 3 layers here that makes up your blood-air barrier for gases to cross over to. Okay, you have your alveoli layer right here. So we're zooming into this area, and we're really zooming into this little space right here. You see how there's these red dots are actually the capillaries. So we look at the capillary, and the thin layer of pneumocyte type 2 is what we're looking at here. Here's that capillary circle, and here's part of the alveoli sac. Okay, so this is the alveoli epithelium right here by your simple squamous epithelium. This is the capillary endothelial layer right here, the red. And then you have the gray here in between, which is a fused basement membrane that connects the two together. Okay, so these 3 layers are already kept as simple as they can to allow for efficient and rapid gas exchange that our lungs need to consistently do. And this blood-air barrier is actually very efficient in what it does because of these 4 things. First of all, you have very short distance of the barrier for gases to travel to from the lungs toward the red blood cells. Just these 3 tiny little layers. 2 of them are made up of single cell, if anything, and then these are your 1 little tiny layer of basement membrane. So diffusion will proceed very rapidly. And on top of that, remember we talked about oxygen and carbon dioxide are small enough that they can cross over your plasma membrane very easily. So you don't need a channel or a pump or any sort to get these gases across each other. And lastly, your surface area of the blood-air barrier is very large due to the millions of alveoli that you have in each lung. And there's a reason why alveoli are in these curvature like grapes is because all these curvature is what provides and adds to that large surface area you're able to provide for gas exchange, okay? So we'll talk about some diseases that compromises the surface area, then which leads to lower amount of gas exchange that can happen and limits the ability for the person to breathe or use oxygen efficiently. But all of these reasons are why this blood-air barrier becomes a very important medium for fast and efficient gas exchange. Now, we all know pneumonia is a more serious respiratory disease. Now we can understand why, because pneumonia involves infection and inflammation that directly affects the function of this blood-air barrier that we were talking about. The infection causes fluid to leak into the alveoli. Remember I said what's in here is supposed to be nice, just very thin layer of water around, and then the rest of it is supposed to be air. Okay, when you have pneumonia, the inflammation can cause fluid to seep through into the alveoli, so your alveoli is filled with fluid instead of air. And this really limits the ability for gas exchange to be happening efficiently when you have all these fluids stuck in your alveoli. Respiratory bronchioles will swell as well due to the inflammation, which means there will be constriction of airways. And overall, all that lung is supposed to do to provide us with oxygen and allow carbon dioxide to come out, all of those becomes compromised when you are infected with pneumonia. Now, there are a couple things that can cause pneumonia. Bacteria, virus, or even fungi can lead to different levels of pneumonia. Some are severe cases of pneumonia. Some are mild cases where they can recover on their own. And including, the pandemic right now with COVID-19, that can cause pneumonia as well. So prognosis of pneumonia can also differ for different individuals. But pneumonia can become life-threatening for a different individual, depending on age and also the health status of their respiratory airway and their lungs. So there are other anatomical structures for the lungs that we have to address. Okay, just like the heart had an apex and a base, the lungs do as well, but they're just on opposite sides. How nice. The apex of the lungs, because apex is pretty much referring to somewhere that's pointy. So the apex for the lungs is actually on top right here, where it tapers off to a tip at the top of the lungs, and then the base of the lungs is down here on the left and right lungs, which is where they rest on the diaphragm. Okay, the diaphragm's right down here, and so this is really that base of the lung sitting on top of the diaphragm. Now, something unique about the left lung, due to the fact that it has to make space for the heart, okay, because remember the heart sort of point towards the left side of the body from the midline, if you remember from the cardiovascular chapter. That is a reason why the main bronchus of the left lung is more angled than the right lung, because it needs to make room for the heart. The other thing is that the lung itself, the lung tissue itself, has to make room as well for the heart. So that's why here in this area you see a nice curvature on your left lung, is because that's allowing for the heart to sit in that area. So this is that cardiac notch. Okay, so it's called a cardiac notch in this area, and it allows the heart to sit right there pointing towards the left side between the two left and right lungs. Okay, so cardiac notch, and it's easy to remember, it's literally a notch, okay, because it curves and it's for your heart, so that's why it's called the cardiac notch. And just like the heart, we have to review the two serous membrane that lines the lungs, because they are the very reason we can allow the lungs to expand and recoil in shape that allows for the physical mechanism for us to breathe properly. We have already learned from last semester that each lung sits in its pleural cavity, and they are surrounded by a double-layered membrane. The layer that is in contact with the inner surface of the thoracic cavity wall and the diaphragm is called the parietal pleura. So that is this outer layer right here, okay? This outer layer that is right next to your ribs and your thoracic cavity muscles. The layer that is in direct contact with the lung surface is called the visceral pleura. So that's this layer right here. Okay, so you see how it's one layer coming down and then another layer. Okay, so that's why it's a double layer membrane, just like your heart. Okay. And in between these pleura layers is where they secrete pleural fluid into the pleural cavity space. And that pleural fluid serves to provide a slippery surface for lubrication between two layers when we are breathing, just like how our pericardial fluid is to help with lubricating every time your heart is moving against other tissues when it beats. Our lungs is the same way. Okay, our lungs have to expand and recoil, and that double membrane with this pleural fluid is what prevents our lungs from rubbing against other tissues when we breathe, and also it serves a very important purpose that I'll talk about in a bit. Actually, I'll talk about it next, is for pulling on the lungs and allowing the lungs to expand. Now, similar to the case with the heart on pericarditis and cardiac tamponade we talked about, pleurisy is the condition when the normal coating of the pleural fluid doesn't prevent friction between the pleural surfaces. And because there's not somehow that pleural fluid maybe is not enough or something that causes two layers to rub against each other, that can cause pain and inflammation. And when inflammation starts to happen, you actually ends up doing the opposite of what you want it to do, is it would actually mix excessive pleural fluid secretion into the two pieces of pleura, or it may even cause the two pleura surfaces to adhere to each other and stick to each other, both of which will make breathing a lot more difficult than when you have your nice pleural fluid in between, enough of amount. So that's why I say it's kind of like your cardiac tamponade, how cardiac tamponade, because there's so much fluid within your pericardial space that it restricts the movement of the heartbeat. Same thing here. If you have a lot of secretion of fluid into your pleural space, then this is all going to be filled with fluid down around here, and you're going to restrict the ability of your lungs to expand and recoil. Now, pneumothorax is actually a common condition. Again, oftentimes, the pneumothorax is illustrated by a lot of medical dramas and movies to make it more dramatic, where either the outside source or your ribs themselves are broken and it starts stabbing into the pleura. And when a hole is created either in the pleura or the, you're talking about either the visceral or the parietal pleura, then air will enter into the pleural cavity. And this can happen on either the parietal pleura side or the visceral pleura side. Regardless, the air breaks the fluid bond between the pleura. So let's say there's a hole right here. Let's say someone stabbed you in that puncture hole, or the ribs, a broken rib stab into that area, resulting in a hole within your pleura layer, and air is just going to go right in to that space, okay, and it starts shrinking your lungs. When air goes in there like that, it actually pushes and forces the lungs and limits the ability for the lungs to expand. Kind of like what happens, like I said, with the cardiac tamponade. Instead, the pleura is now filled with air and not fluid, and you can end up with a collapsed lung called atelectasis. Okay, atelectasis, like this, when you have air flowing into that pleural space that causes your lungs to collapse. And the way to treat this medically is they will insert a needle or a tube in there that will allow air to escape back outwards. to remove and remove all that excess air and allow the lung to expand again, and you're now able to breathe. Kind of like in an emergency situation, as portrayed in the movies, where they always show in medical dramas. You see this doctor happen to pass by a person suffering from pneumothorax after stabbing event or a car accident, and they're trying to save them in a life or death situation. They end up using an open end of a pen or something and stab it into the body on the chest to relieve that air pressure, and you see the person go like that again and can breathe. The person, it's kind of like that's what happens. It's nothing something. Now, this is nothing that's something a person should mimic without medical practice, but you get the idea of pneumothorax is from that illustration of those medical drama. And that's why so many movies and TV shows always incorporate this condition into their storyline, because it makes the action more dramatic on the scene. But don't do it on your own. Stabbing the pen into the chest, it may cause infection in someone, and you don't know how deep you're stabbing into, unless you're a medical personnel with practice on that purpose, for that very purpose. Okay, so now that we are doing, we're done going through with the anatomical structures of the respiratory system, we're going to get into the physiology of respiration, which is the more complex part of this lecture. So respiration is separated into the external versus internal type of respiration. External respiration is referring to the gas exchange of oxygen and carbon dioxide between the body's interstitial fluid and the external environment, which is pretty much between your lungs and your blood. Okay, so this is your blood and this is your lungs. So we're talking about gas exchange between them two. Whether we're going oxygen is flowing this way or carbon dioxide is flowing this way. That's called external respiration. So what is happening between the lungs and blood here is what we're talking about. Internal respiration is absorption of oxygen by your cells within your tissues and release of, so oxygen gas goes from your blood into your tissues, and then you will have collection of carbon dioxide from your cells and tissues back into the blood to be delivered back into the lungs, okay, the lungs here. So what's happening between the blood and your interstitial tissue is what's called internal respiration. Okay, so in a sense, it's kind of like pulmonary circuit versus a systemic circuit for the cardiovascular system. The pulmonary circuits involve external respiration right here, while the systemic circuit involves the internal respiration. Okay, just think of external kind of sounds like exterior, so we're inhaling air from the exterior environment, and internal sounds like something inside. Okay, so this is something between your internal tissues and the blood vessels. Okay. All right, so external respiration itself would include 3 integrated steps. You have pulmonary ventilation, gas diffusion, and transport of oxygen and carbon dioxide. We'll discuss these 3 steps in details and the physical mechanism behind how does oxygen or carbon dioxide knows which direction to travel without a pump or anything. It's all kind of based on pressure numbers. So pulmonary ventilation is talking about breathing, that physical movement of air into and out of lungs, and there's a specific law called the Boyle's law that illustrates this process, how we're able to inhale and exhale air. Gas diffusion is what the alveoli is doing for us with that blood-air barrier we just talked about, and then we'll discuss the different pressures at different places that allows for that exchange of gases. And lastly, we'll talk about how oxygen and carbon dioxide is traveling within the cardiovascular and respiratory system. Okay? All right. Any abnormality that occurs at any of these three steps can actually change the concentration of gases within the interstitial fluid, which means cells won't be receiving enough oxygen. A condition where we already learned is called hypoxia, and that can affect the heart in terms of coronary ischemia. And if it gets to anoxia situation in the brain or the heart, anoxia means completely cut off of oxygen supply, like a plaque or a blood clot, then it will lead to a stroke or a heart attack. So hypoxia, when we're talking about low oxygen level, anoxia, complete cutoff of oxygen levels. So let's start with pulmonary ventilation first, talking about the three mechanisms behind the ability to breathe. So how does air knows when to move into lungs and when to exit out of lungs? It's not like there's a command we can give to the air, hey air, please come in now. There's no pump either. So it's all driven by gas laws that we already had a glimpse of when I was explaining how respiratory pump works for the veins in the blood vessels chapter. Again, the words pulmonary ventilation is defined as maintaining adequate amount of air into and out of the alveoli. That's what pulmonary ventilation means. Notice that it doesn't say lungs, but specifically alveoli, because that's where gas exchange happen. It doesn't help in any way if air is only getting into the trachea without going all the way down into the alveoli. So it is very simple concept of needing to supply enough oxygen to the bloodstream and prevent buildup of carbon dioxide in the body. Okay, so that's all that pulmonary ventilation and respiration is trying to do. So one of the gas laws that explain how pulmonary ventilation works is called Boyle's law, where it puts the value of pressure and volume into a correlated relationship. At normal atmospheric pressure, for example, if we imagine the air that is in an open space out in our backyard right now, for example, the forces acting between the gas molecules are very minimal because they are too far apart for any weak molecular interactions. So they're just diffusing and moving all over the place in the air of the backyard. But if we imagine a sealed container, like our lungs, or a small box that looks like this, for example, or like this, gas molecules are going to bounce off the walls of the container everywhere pretty quickly because they are put into a confined space now. It's not an open atmosphere, but now we are in this confined space defined by the box, or in the case of our lungs, okay? And gas molecules are going to be, colliding into each other, bouncing off of each other. This collision of gas molecule is what really creates the value of pressure. Okay, the reason why we have certain numerical number representing the pressure inside a tank or inside of certain areas is because of these collisions that are formed by these gas molecules. So the higher amount of collisions you have, the more pressure there is, or higher the pressure value there will be between gas molecules. And hence, as you can imagine, this pressure can be affected by how big that sealed container is. How confined is this confined space, which then is related to the volume value of the container itself. Okay, so the larger volume the container is, the more room there is for gases to roam around, and they will be less likely to collide up against each other, which means less collisions. Less collisions then will be which will mean that there will be less pressure, okay, within that larger container space. Now, on the contrary, if the container has a smaller volume, there will be less room for the gases to roam around. Okay, they will be bouncing off the walls like crazy, like this. Okay, so imagine this is a little ball right here on my pointer and just going like this all over the place as they're bouncing around that small little confined space, versus a larger space like this. They will move a lot slower and less likely for these black dots to be hitting each other. Whereas a small box, you will have a lot higher chances of collisions of these gas molecules, so there will be more gas collision with a smaller volume container, and hence there will be a higher pressure when you have more collisions. And hence Boyle's law states that pressure of gases is inversely proportional to the volume of the container that the gases are placed in. Okay, so this is a very important relationship right here for the Boyle's law. Okay, if, for example, the volume is doubled, your pressure will always be halved. If your volume is half, then your pressure will be doubled, which is why we have the Boyle's law written in a formula like this, where P for pressure is inversely proportional to to the volume. So that's why you put 1 over V, because it's an inverse proportional relationship. Okay? All right. So if we apply the concept of Boyle's law to our lungs, we can understand how pulmonary ventilation works. A single respiratory cycle, like, for example, the same way with our cardiac cycle, a single respiratory cycle consists of inspiration or intake of air and expiration, breathing out air. Both involve changing the lungs' volume to create different pressure gradients that will move air in and out of our lungs. So the lung volume is then dependent on the size of the thoracic cavity, mainly, that can be changed according to what the diaphragm is doing. Remember, the diaphragm is acting like the floor or the bottom of the thoracic cavity. So this whole thing here is the thoracic cavity. This right here on the bottom is the diaphragm. And when the diaphragm is relaxed, okay, the diaphragm is actually in a curved dome shape like this. That's in its relaxed mode. And the base of the lungs is sitting directly on top of the diaphragm. So during inhalation, what happens is the diaphragm will contract, flattens out. Instead of a curved shape, you have a flattened shape right here, which allows the space, okay, it really, when it flattens out, it increases the amount of space that's created in the thoracic cavity. When the space increases, that means the volume of lungs increases. And according to Boyle's law, when the volume of your lungs increases, the pressure of that area will decreases, okay? And gas acts just like solution. It always goes from an area of higher pressure to an area of lower pressure. So now that the pressure inside the lungs is lower than the atmospheric pressure, atmospheric pressure, because the pressure now has decreased, this is lower than the atmospheric pressure, and gas flows from higher concentration to lower concentration. Air would just flow right in to your lungs, okay? So that is how we are able to do inhalation. Now, exhalation would be the opposite. When you exhale, you allow your diaphragm to relax this way, okay? And this decreases the volume of your thoracic cavity, which means the volume of your lungs goes down, okay? If volume goes down, according to Boyle's law, the pressure in your lungs goes up. And again, because the air, gas will travel from an area of higher concentration to an area of lower concentration. The fact that pressure has increased is what's going to force the air from your lungs outwards into the atmosphere. So this is how we are able to achieve exhalation. Okay? So this is inhalation, this is exhalation, all regulated by what our diaphragm is doing down here according to the volume changes within the thoracic cavity, which then have a direct relationship to the pressure that is changed within the lungs. So now you can see why, this our diaphragm has a lot to do with our ability to breathe. Now, the movement of rib cage also has an effect, although not as pronounced as a diaphragm, but it also has an additive effect to the volume of the thoracic cavity as well. When you breathe in, the rib cage will move outwards and allow for more space and volume in the chest. And when we breathe out, the rib cage will go back to its original position to decrease the volume. Okay, so if you imagine your rib cage here doing this, okay, that surrounds your lungs, when you breathe in, they kind of move upwards and outwards that way to allow, further expand your thoracic cavity, allow for more volume space for your lungs to expand. And then when you breathe out, they will come back down to its original position, which means it helps with that exhalation as well when it decreases in volume of the thoracic cavity. And so now you may ask, just because the thoracic cavity is expanding, that doesn't mean we're pulling on the lungs to expand. So why does the thoracic cavity volume is directly affecting the lungs volume? What I mean by this is, so you have your lungs this way. Okay, and then you have your thoracic cavity around it. So when your, the diaphragm becomes flat like that, and you have this huge thoracic space, why won't your lungs dangle like this? And, why does it expand like this in this situation instead of dangling like this? Just because the thoracic volume increases doesn't mean the lungs will expand. But so what is causing the lungs to expand along with the volume increase of the thoracic cavity is the question we're asking here. So remember that the lungs is covered by your parietal and visceral pleural layers, okay? Other than serving the purpose as lubrication, I mentioned earlier that these two layers are making sure your lungs expands. In between your parietal and visceral pleural layers, you have a film of pleural fluid that acts somewhat like a suction that causes the surfaces of each lung to stick to each other to the inner wall of the chest and diaphragm. And in a sense, the pleura then is what pulls the lungs to expand when the volume of the thoracic cavity expand. So here again is your lungs, okay, and it's surrounded, here again is your lungs, and it's surrounded by that double layer membrane we were talking about that serves to surround your entire lungs, okay? So when your thoracic cavity expands due to flattening of your diaphragm down here, first of all, remember that your parietal pleura, it's stuck to the thoracic cavity. So that is going to be pulled outwards, okay? And the visceral pleura is also pulled outwards this way because of that fluid within that space that acts as a suction due to surface tension between the two layers, okay? And there's actually a term for this. It's called intrapleural pressure. But I just decided to not talk too much about that because it gets confusing. Just understand that there is an intrapleural pressure between the two pleural layers that allows for that suction of your lungs to be pulled this way. Okay, now that visceral pleural layer is also attached to your lung tissues, which means that visceral pleural layer is what pulls the lungs as well outwards when those fluid layers are pulling your lungs. Okay, so in a sense, your thoracic cavity is pulling on the parietal layer, and the parietal layer is pulling on the visceral layer, and your visceral layer being attached to your lungs is what allows your lungs to expand just like this. Okay, so let's say if there was no serous membrane, then you can have as big of a thoracic cavity you want. Okay, but if there is no membrane there, your lung is just gonna dangle like this. Okay, so which is the reason why when your pleura is compromised by something stabbing into it in the situation of pneumothorax, that's why your lungs end up being collapsed in a small little dinky thing like that instead of being able to expand to the size of your thoracic cavity. So that tells you the other very important function of these pleural layers. Okay. And let me erase that. Okay, and this next animation I will show you is show you a sort of in a dramatic view of what the diaphragm is doing to change the volume of thoracic cavity and hence the lung volume as well. So this is when the diaphragm flattens out, diaphragm relaxes, pushes upwards. Okay, so that diaphragm's moving upwards, downwards in that dome shape that will push the lungs upwards into the thoracic cavity or downwards, allowing the lungs to expand. Okay, so that's what the diaphragm is doing to help change the thoracic cavity and hence the lung volume. Okay, so we know that the force of our breath can differ depending on how deep we are breathing, and hence there is a difference between what's called quiet versus forced breathing. During normal quiet breathing, we call that eupnea. Okay, this is when inhalation requires muscle contraction of the diaphragm and the external intercostal muscles, while exhalation itself is a passive process, meaning that it just involves relaxation of muscle. It doesn't require any muscular contraction. So no muscle contraction required for passive exhalation during quiet breathing. The only part of breathing that will require muscle contraction in a normal quiet breathing sense is just during inhalation, not exhalation. And when we use our diaphragm to breathe, is actually called diaphragmatic breathing, which involves deeper breathing when we can change or dramatically change the volume of our thoracic cavity. When we're just using our external intercostal muscles to raise our ribs, for example, for breathing, it's called costal breathing. And it's considered to be shallow breathing because it doesn't really change the thoracic cavity volume by very much, not as much as our diaphragm. And a lot of times with pregnant women, especially in their third trimester, they will rely more on costal breathing than diaphragmatic breathing because the enlarging uterus will be pushing up on those abdominal organs upwards against the diaphragm, which then doesn't give it a lot of room for the diaphragm to flatten out downwards whenever you're trying to breathe out, whenever you're trying to breathe in. So that's why, pregnant women in their third trimester will do more quicker breathing, or they may actually have times where they feel like they're in shortness of breath and require more on costal breathing because of that. And that's why women in their third trimester have to sleep on their sides versus flat on their back as well. Okay. And forced breathing then is called hyperpnea. So you can already tell Hypopnea, nia, means breathing, and hyper means too much. Eu usually means somewhere around the normal range. Okay, so eupnea, hyperpnea. So hyperpnea involves both active inhalation and active exhalation. Active meaning both will require muscle contraction of some sort. Okay, so quiet breathing, exhalation, is a passive process. Forced breathing, both inhalation and exhalation becomes an active process where they both require muscle contraction. And during inhalation, other than the diaphragm and external intercostal muscles during the contraction, the pectoralis minor muscles will also assist in expanding the thoracic cavity outwards. And during active exhalation, the contraction of abdominal muscles right there, like the rectus abdominis, will assist with pushing the diaphragm even further upwards that way. To push it in, into the thoracic cavity, really minimizing the volume in there and pushing and forcing the air out of the lungs quicker and stronger than, when you're doing just normal passive exhalation. So the internal intercostal muscles also helps with this process by depressing the ribs. So all of these muscles will participate together to allow for maximum level of forced breathing. Okay, so don't forget the pectoralis minor in inhalation and rectus abdominis and internal intercostal muscles participating in exhalation. Okay. Okay, and as we have already discussed, the pressure of lungs changes according to its volume when we breathe in and when we breathe out. And we understand now that the direction of airflow is determined by the relationship between atmospheric pressure and what's called the intrapulmonary pressure. Or you can call it also intraalveolar pressure, which is the pressure within the respiratory tract that I was putting as P increase or P decrease. Okay, P decrease, P increase. Okay, due to volume increase or volume decrease. Expiration, inhalation. Okay, so that pressure I was referring to here is that intrapulmonary pressure. And during inhalation, your lungs expand, which means your volume increases, then which according to Boyle's law, intrapulmonary pressure will be dropping. And we can define that as -1 millicurie according to this chart right here. -1 millicurie when we're doing inhalation. And during exhalation, your lungs will recoil, which means it will decrease in volume. And that, according to Boyle's law, intrapulmonary pressure will now increase to +1 millicurie. So this right here, +1 millicurie during exhalation is what's going to push the air outwards. Now, the degree of pressure changes will depend on how an individual breathes. For example, a trained athlete can actually be breathing at a maximum capacity where they can reach up to -30 millicurie during inhalation. And because when you are doing strenuous exercise every day as a routine part of your day, you are working out those breathing muscles as well and allow them to become stronger, which will allow for more changes in the respiratory volume by allowing for more expansion of the thoracic cavity. So just as there are factors that can affect cardiac output, there are, of course, factors that can affect pulmonary ventilation as well. And one of those factors is called compliance, which is basically a measurement of how easily expandable your lungs are in response to different pressures. Having a lower value of compliance means that it will take greater force or pressure to fill the lungs with air. Or simply put, lungs with a lower compliance value cannot easily expand, so it would take greater force to fill the lungs. Having a higher compliance value means that it takes a lot lesser force to fill the lungs with air. And in other words, lungs with higher compliance will always be easier to expand. So, what are some things that can affect your lungs' compliance value? One of them will be the connective tissue that makes up your lungs. Okay, for example, your alveoli. If there's a loss of supporting tissue due to some sort of alveolar damage, then that will increase the compliance value. For example, in the case of a lung condition called emphysema, which is a disease oftentimes caused by long-term smoking with chemicals damaging those tissues, over time those air sacs will become weaker and eventually rupture. Ultimately, the smaller alveoli will fuse together to form large alveoli sacs that will fuse together to give you bigger holes. Remember I said the whole purpose of these alveoli is to create all these little curvatures that allow for a lot of surface area. Here you have a lot less surface area now because you have bigger holes instead of smaller holes. Now, there are two things being affected here when you have emphysema. First, it does increase the compliance value when you have emphysema because now it's easier to fill the lungs due to the fact that you don't have as many little balloons to fill. You have less surface area for the air to pass and for the air to have to flow past. And just like blood vessels, less surface area, less resistance, okay? So having less resistance makes it easier to fill the lungs. Higher compliance value. So yes, it is easier to fill the lungs for emphysema, but the other thing that is more detrimental to the lungs' function is the surface area decrease. All of those little curvatures formed by millions of your alveoli, we have in our lungs is for increase in surface area. Remember that is a common theme in human anatomy. The more curvature means more surface area in order to pack all that surface space into a tiny human torso. So the total surface area of all the alveoli combined together from a person's lung is actually almost as large as a tennis court. Imagine a whole tennis court fit into your small thoracic cavity. And hence, what is being compromised in a person with emphysema is the amount of all that surface area space. So instead of having those little curvatures here, you have now these, their alveoli will have large surface spaces instead, not surface space, but large spaces instead. There are less curvatures, which means there are less surface area. They end up not having enough space for gas exchange like a normal person would, and hence this is why individuals with emphysema ends up constantly feeling like they don't have enough oxygen, is because their lungs alveoli surface area for gas exchange has been greatly reduced due to the disease itself, causing fusion of the alveoli sacs. But in terms of compliance value here that we're talking about, compliance value, whenever you have emphysema, it does increase the amount of compliance value, but that may not be a good thing in the case of emphysema because it reduces the surface area available. Okay, another factor that can affect compliance value is the level of surfactant that is produced. We have mentioned earlier that pneumocyte type 2 cells are the ones that are responsible for making surfactant within the alveoli to keep them from collapsing on each other. So if not enough surfactant is not made by those cells, the alveoli will technically be possible to collapse upon exhalation, and they will have to inhale a lot harder to fill, to inflate those alveoli again. So the lower production of surfactant actually result in a lower compliance value, which means it's harder to fill the lungs. And lastly, how mobile one's thoracic cage is also plays a role in compliance value. For example, if a person has arthritis or something, or other skeletal disorder that can affect the movement of your ribs in general, it's harder to increase the size of the thoracic cavity, which means it's harder to fill the lungs, and that will also mean a decrease in compliance value. So make sure you understand these factors that can affect either increase or decrease compliance values. So a lot of times how an individual's respiratory functions is evaluated clinically is by measuring different respiratory volumes, kind of like how we can calculate cardiac output with heart rate and stroke volume. Remember, CO equals to HR times SV. So we can calculate how much air is being moved by our lungs with this similar formula. We call this the respiratory minute volume, which is one's respiratory rate, defined by F here, means how fast you can breathe, and is multiplied by one's tidal volume, denoted by VT here. Tidal volume is defined as how much air you can breathe in and out with a single respiratory cycle, meaning inhalation followed by exhalation during normal breathing. So for example, an average person respiratory rate can range between 12 to 18 breaths per minute. So if we take 12 breaths per minute, for example, multiplied by an average person's tidal volume, which usually is 500 mils per breath, you get about 6,000 mils or 6 liters of air per minute. That is your respiratory minute volume. Now, but this is not an accurate measurement of what's actually being used for gas exchange. Not 100% of the air we breathe in will be able to make it all the way down to the alveoli for gas exchange. Some may remain in the trachea or the bronchi, then flow right back out during exhalation without ever reaching the alveoli. So we must account for that, because after all, what matters is the amount of air that actually goes all the way down to your alveoli for gas exchange, providing your body cells with oxygen. So the amount of air that doesn't participate in gas exchange is called anatomical dead space, denoted by VD here. Okay, VD. Anatomical dead space volume, which is on average about 30% of your tidal volume. So if we take 0.3 times by 500 mils, that's equivalent to about 150 mils of air that is not really doing anything and flowing right back out. And so a more accurate to represent how much air is actually participate in gas exchange is the value in what we call the alveolar ventilation volume, or denoted as VA. So now we can take this anatomical dead space volume into account with our formula here. We take our normal average tidal volume subtracted by our anatomical dead space volume, which is 500 minus about 150. So it will be 12 times about 350 to get 4.2 liters per minute. Okay, this is an actual value of your alveolar ventilation, how efficient the air, or how much air we actually use for gas exchange. All right, so if we correlate these three different types of volumes, we can say that for a given respiratory rate F, increasing the tidal volume by breathing more deeply will be able to increase your alveolar ventilation rate. For a given tidal volume, if you're just going to keep your depth of breath the same, increasing respiratory rate by breathing faster or more quickly. By increasing your F value, we'll be able to increase your alveolar ventilation rate as well. So either increasing how fast you breathe or increasing how deep you breathe, or both, okay, will be able to enable for increase in your alveolar ventilation rate. So the average alveolar ventilation volume is not the only volume we can look at to evaluate the efficiency of our lungs. There are other volumes involved in the analysis of one's respiratory system. Kind of like instead of measuring blood pressure to evaluate health of the cardiovascular system, we can measure air volumes instead to assess the health of our respiratory system. How one measures different air volumes is actually by using an instrument called the spirometer, which is a device that you can blow air into to measure the volume of air. You will see this instrument in the respiratory physiology lab when you get there. So here are the different volumes that can be evaluated. We already talked about the tidal volume, which is just a volume you breathe in and out in a single normal respiratory cycle. Okay, so this right here is representing that 500 ml volume of you breathing in and out, tidal volume. And inspiratory reserve volume then is the amount of air you can take in above the tidal volume. So this right here, from here to here, is what you can take above your tidal volume. Expiratory reserve volume, abbreviated ERV, is then the amount of air you can voluntarily expel below your tidal volume. So this is the end of your tidal volume. So from here to here is your expiratory reserve volume. Now, residual volume is actually the air here that remains in your lungs even after maximum exhalation. We can never get rid of this residual volume due to a reflex that we'll learn at the end of the chapter called the Herring-Breuer reflex that has to do with how much we can exhale out. But we can never go below this ERV volume because that's the way our lungs work. Our lungs cannot be collapsed. If you were to breathe out this residual volume out completely, then your lungs will end up collapsing, and that's not a good sign. There's also another volume down here called the minimal volume, which is an amount of air that remains in your lungs even if they were allowed to collapse, okay? Meaning that if they were collapsed, there's still that tiny little bit of air inside of your lungs, and they can never, this volume actually can never be measured in a healthy person unless they're dead, okay? All right, and the vital capacity is usually what's being evaluated in terms of how efficient your lungs are working, or how well your lung is working. So the vital capacity is talking about from the maximum amount of air you can inhale all the way down to the maximum of air you can exhale. So basically, it is the sum of your ERV, your tidal volume, and your IRV. Okay, so all IRV, tidal volume, and then ERV together equals your vital capacity. And in the lab on respiratory physiology, you'll have a chance to measure your own vital capacity if we are ever, if you were to go into lab, in an actual lab. And the total lung capacity then is the total volume, including your vital capacity, along with the residual volume right here. Okay, so sum of your vital capacity and residual volume, and here is a good reference chart for you to know the gist of these different volumes, whether you're a male or female. Males always tend to have a larger vital capacity and IRV, ERV, just due to their anatomical feature that are different from females. All right, before we get into the other parts of the physiology, the rest of the chapter, I will stop here for part 2, and we will continue in part 3.